Good morning or good afternoon, wherever you are in the world. I have the distinct pleasure of being here with Dr. Hatem Soliman Aboumarie. I'm Nick Villalobos. I'm here in Houston, Texas. Dr. Soliman is in London, and we're going to be talking about the new consensus guidelines and statement from the European Association of Cardiovascular Imaging. Um, uh, and maybe I guess to start off for our audience, Hatem, are you okay if I call you Hatem?
Yeah, of course.
Um, Maybe let's talk about why we're even going through this conversation of cardiac ultrasound versus, echocardiography per se.
Yeah, first of all, thank you very much for having me, Nicholas. It's a great pleasure. This is actually something that we discussed with the author panels in the very early beginning of conceptualizing the consensus document. And we agreed to choose the term cardiac ultrasound because it's broader than echocardiography, because the document does not only focus on uh, echocardiography, but also discusses thoracic ultrasound and systemic venous ultrasound. So it's a rather holistic approach, which is actually what we do in real life in our intensive care units.
Yeah, absolutely. And I know you are a hemodynamics master. And I myself deal with a lot of cardiac patients, a lot of post-cardiotomy patients. And how are you coupling invasive and non-invasive hemodynamics? I guess now we're understanding more about utilizing spectral Doppler to get to pressure gradients. Are you using one modality or the other, or how are you coupling that?
So actually, I work in a cardiothoracic intensive care unit in a quaternary referral center. So we have complex cohort of patients, cardiac surgical, cardiogenic shock, transplant, MCS. So I think for our patient cohort, it's very important to combine pulmonary artery catheter with ultrasound. I don't think one replaces the other. We use them both in patients. So I think the context and the clinical category and intensive care have different types. You have general intensive care, you have trauma ICUs, and that will determine whether you will need invasive hemodynamic monitoring or not. In our situation, we use it. It remains the gold standard for hemodynamic monitoring, which is pulmonary artery catheter, but we equally use a lot of ultrasound in our patients. And sometimes in these complex patients, you have to use as many data as possible at the bedside and try to align it and look in the context of the clinical background, especially as we know that each of these parameters have some pitfalls. We know that there is a good correlation between echocardiography and invasive hemodynamic monitoring in terms of cardiac output, PA systolic pressure, but there is limited correlation when we talk about filling pressures, left ventricular filling pressures, for example. But we already have data, registry-based data that PA catheter use to phenotype patients with cardiogenic shock uh, does improve survival, which is important. And that's why I don't see echo as a replacement to pulmonary artery catheter in our patients. But as I said, there are certain pitfalls and some limitations for each of these modalities.
And that's a great point that you bring up. I know your guidelines also mention training pathways and something to that effect of getting people intensivists specifically that are more facile with doing a focused cardiac exam or more advanced critical care echocardiography. Can you speak to that a little bit more?
I think this is really important, and it's now more important than ever with the widespread availability of point of care handheld devices. Now, ultrasound is in the hands of many, and it's becoming more and more available in our intensive care units. And it's fundamental for intensivists to learn ultrasound. So it's becoming more and more important to learn how to do it and also learning the pitfalls and the limitations because we all know now in our ICUs around the world, patients are more sicker. So that leads to more complex patients and more challenging interpretation. And that's why we thought it's important in this consensus document to provide updated guidance on the levels of training and the levels of accreditation, because there was a paradigm shift over the last years in what was deemed simple or base or what was deemed advanced, and now it's becoming less advanced and more available. For example, pulsed wave Doppler and LVOT VTI. A few years ago, it was considered an advanced parameter, and now I think it's becoming more and more towards the basic or intermediate level at the bedside, especially that most handheld devices have a pulsed wave Doppler. And that's just one of the examples why training pathways and accreditation pathways are very important to empower our colleagues to practice ultrasound safely at the bedside, because ultrasound in the wrong hands can be harmful.
Absolutely. And I guess more of an interest of my own, you know, AI has started coming into ultrasonography. And as you mentioned, with the handheld devices, even with our cart-based devices, there are a lot of, let's say auto EF, auto VTI, even strain is starting to get on that level too. Are you yourself using that, or any of your colleagues starting to use the auto features?
Yes, we do have them in some of our machines. In our ICU, we have the wide spectrum of ultrasound devices, from cart-based to very small handhelds, and some of them have AI features. I think it's very useful, very exciting, but I don't rely on them yet. I still need to, or often I need to confirm the measurement, because I still see some errors in the auto VTI measurement. I don't think we should blindly follow them yet. It's a great advancement. It really expedite assessment, but it's a work in progress. I think so far the best progression of AI in echo has helped outpatient settings, where you have streamlined workflows, integration, and now you have available softwares which are FDA approved and CE marked, which can provide a complete echo report based on few images in 10 seconds, which is a revolution. And this is not a futuristic tool. This is a real life tool. But in critical care, there is still some work, because we know that critical care echo is very dynamic, it's personalized, challenging windows compared to outpatient settings, and that puts some limitations. But I'm a strong advocate for AI in ultrasound, but I still think we need to do a lot of work. Technology needs to improve, and we also need to validate it. And I don't think that it replaces our human interpretation or human assessment as yet. And that's for the non-strain aspect. Regarding strain, I have some reservations. I think strain is very exciting. We have data, established data, that strain is much more sensitive, even in ICU settings, in detecting septic cardiomyopathy, for example, prognostication. We have data on the role of strain in assessing the right heart after LVAD and predicting RVAD implantation. But ICU environment is challenging for strain. For strain, you need a clean ECG signal, which is often difficult to acquire in or have an ICU. You need optimum windows, which are also challenging to get in ICU. And I think most importantly, strain assesses contractility. And we know that contractility is not our focus in critical care settings. Our focus is on perfusion and cardiac output. And there are many situations where contractility can be misleading. You can have normal contractility with cardiogenic shock, and you have very poor contractility with normal cardiac output. And that's why I see strain less useful in the very acute settings.
That's fantastic insight. I think jumping off that point, I'd like to go a little bit more into the weeds in terms of our post-cardiotomy patients, or the prototypical patient that we see in the cardiovascular or cardiothoracic ICU. When you're dealing with a failing RV, what are some of the values that you really look into? I know we all have our own way of practicing, and now with like you mentioned, just using VTI as a surrogate has become sort of a basic understanding for intensivists. What else are you doing bedside to couple with your invasive hemodynamics for the failing RV?
Yeah, indeed, RV is one of the main aspects of hemodynamic assessment, and I think Doppler is very useful in this context, and I think it's underutilized in assessing the RV. One single window can be extremely useful, which is the short axis grid vessels view by TTE, or the upper esophageal great vessels view, because with that, by transesophageal echo, because that you would see the RVUT flow, and by pulsed wave Doppler you would be able to trace the RVUT flow, measure the acceleration time, which in the absence of tachycardia correlates well with pulmonary vascular resistance, and also you can see the shape of the RVUT envelope. We know that if you have mid-systolic notching, that would correlate also with pulmonary vascular resistance, and even more excitingly, that the peak systolic velocity after the notch correlate with RV performance. So if you have a small peak velocity after the notch, that would correlate with poor RV and worse survival. But I like to look at the RV physiologically. Everything we do in ICU, Dr. Villalobos, is based on physiology. So I look at the RV as an afterload, which to me is very important. I start with afterload assessment, PVR, by pulsed wave Doppler. I get RVOT-VTI as a measure of RV ejection, the RV contractility, the TAPSE, understanding some of the limitations of TAPSE, and then I go to the preload and go beyond the chest cavity and assess the venous congestion by pulsed wave Doppler of the hepatic, portal, and renal veins. And to me, this is a rather multimodal assessment of the right ventricle physiologically at the bedside.
Yeah, that's fantastic. And I agree, Vexus has been an entire paradigm shift in the way that we're evaluating hemodynamics bedside. A little bit more on that. Uh, Going into RV to PA coupling, I know this has been a really interesting topic for me recently. Can you just describe RV to PA coupling, or really uncoupling bedside?
Sure. So I think RVP, the ventricular arterial coupling is a very important physiological concept, whether on the left heart or the right heart. And in a normal physiological states, there is a coupled relationship between the contractility and afterload, and that determines efficient cardiovascular system. So in shock states or altered hemodynamic states, this uncoupling could happen, and we can measure it by echo. First, the gold standard is invasive measurement and using PV loops, but you can also use it measure it non-invasively. On the right heart, you can even use a surrogate for that RVPA coupling, which has now been validated as a prognostic marker, which is the TAPSE over the pulmonary artery systolic pressure ratio. TAPSE as a marker of contractility. We know that the right ventricle function is predominantly determined by the longitudinal axis, and the afterload of the RV determined by the PA systolic pressure. This is a powerful ratio, has already been validated and as a predictor of right ventricular failure after LVAD implantation in patients with advanced heart failure, but there are limitations. I think TAPSE itself, although it is very useful, but it has some very important limitations. We know that after cardiopulmonary bypass, TAPSE becomes impaired, so you can't use it reliably to assess this ratio. After heart transplantation, for example, patients with severe tricuspid regurg, TAPSE becomes also less reliable, and also PA systolic pressure, which requires a decent tricuspid regurgitant signal, which can be sometimes difficult to obtain. And if you have severe or torrential TR, where there is rapid equalization of pressure between the right atrium and the right ventricle, but it's a useful ratio. Almost about 0.34 to 0.36 ratio, TAPSE in millimeters over the millimeter mercury measure of the PA systolic pressure can be a quick clue towards the coupling between the RV and the RV afterload.
That's fantastic. Um, going into that a little bit more, we see a lot of these patients that come out post-cardiotomy or even new evaluation of shock, and we're trying to decide whether or not they're vasoplegic or in cardiogenic shock. What's one of the ways that you really kind of dive into this in a quick and dirty manner?
So yeah, sure. Of course, clinical context always, we always use echo in our settings within the clinical context. So echo guides our assessment. We don't follow echo necessarily. So based on the clinical context, I do echo. I start with LVOT VTI. To me, perfusion is the first question. And then the VTI itself as a number can give you some clues towards the type of shock. Because if you have a pure vasoplegic shock, the VTI should be high because of high cardiac output state. But if I see a VTI of 20, for example, which is a normal VTI in a patient with vasoplegia and evidence of low systemic vascular resistance, then I think about mixed phenotype, a mixed cardiogenic and vasoplegic shock, which is not uncommon in perioperative settings. So it is not an assuring figure to see a VTI of 20 in someone with vasoplegia. But of course, we also have to look at the biventricular function, the septum position, the relationship between the RV and LV. And then the first thing I do after that is ruling out dynamic obstruction, which is really important in a shocked patient. Because if you have a high VTI, that can be a consequence of dynamic obstruction at the LVOT or even at the mid cavity of the left ventricle. And that can happen for various reasons, because of inotropes, because of the vasoplegia itself, because of RV failure, which limits the filling of the LV, causing dynamic obstruction, especially after certain types of operations, mitral valve surgery, small concentric LV cavities, basal septal hypertrophy, which you see frequently in the elderly patients. This is all a recipe for dynamic obstruction. And if you identify it, your management will change dramatically because this is an obstructive phenotype of shock. And you have to maybe give fluids and stop or reduce inotropes and reduce heart rate, quite the opposite of what you do for patients with cardiogenic shock. So it's always something we have to keep in our mental checklist. And once we rule out and exclude dynamic obstruction, I proceed to assessment of LV filling pressures with the known limitations of diastology in critical care. I still prefer to look at the deceleration time of the E wave, the restrictive filling pattern, if you see it in a patient with sinus rhythm, can be also a clue towards high left-sided wedge pressure, combined with lung ultrasound and looking for the presence and the quantification of B lines, and then move to the right heart. As I told earlier, we look physiologically into the right heart. Afterload, contractility, RVOT VTI, and then RV preload by VEXAS.
Yeah, I think that's fantastic. And I think you highlight the importance of bedside evaluation and kind of a multi-organ evaluation. I mean, we're doing everything. We're doing cardiac ultrasound, lung ultrasound, VEXAS, looking through the liver, renal vessels as well. You guys go through so much in your recommendations. What are some of the highlights that you just want to point out to the audience?
I think the key thing of the document and the ethos of the document is the pathophysiological approach, which is the thing that it took us 2 years to finish the document, which is slightly longer than we expected. But we as a team are very proud because this is the power of the document, I think. Because this is a real life application of ultrasound. There are several practical guidances around which just describes practical way of doing it without providing this pathophysiological based integration of ultrasound, which I think is the way we should do it at the bedside. You apply the echo data within the clinical context and perform a targeted approach for each category of assessment of heart failure, of shock, and also phenotyping of shock, which is one of the strengths of using cardiac ultrasound. Phenotyping different types of shock and integrating that with the available hemodynamic data with PA catheter and with the other imaging information.
Yeah, that's fantastic. And I know you guys mentioned through your consensus statement too that I think one of the key points of using point of care ultrasound bedside cardiac ultrasound is actually trending your values. I think that's really the strength of having the intensivist do it at the bedside as well.
Absolutely. And that's exactly addressing the limitation, one of the limitations of transthoracic echo, because it's a snapshot assessment of the heart. And that's one of the advantages of PA catheter, on the other hand, where it provides continuous hemodynamic monitoring. And there is already data which showed that serial assessment by echo is much more useful at the bedside than a single measurement by echocardiography. So it is much more useful to look at the trend of the VTI or the delta VTI than just looking at the number itself.
Fantastic. So, I'm so thankful for your time. I don't want to take too much of it, but for the trainee or for the fellow intensive care that's trying to learn echocardiography or critical care echocardiography, what are some recommendations for somebody just starting out?
I think now we have different modalities of ultrasound. We're talking to intensivists, so I usually suggest they can start from non-cardiac ultrasound. They start from lung ultrasound, which is very easy to learn, very steep learning curve. They get familiar with the machines, with how ultrasound looks, and also they finish training quickly. So it gives them confidence and very useful at the bedside. Lung ultrasound now is integrated in the international guidelines in heart failure management. So I suggest to many of my fellows starting the training to start with lung and then proceed to heart. And then, of course, there are levels of accreditation and training. You start with level one and then level two, and then higher levels of training until you reach to specialist levels of training in echo. For those who want to practice echo in mechanical circulatory support, they have to start first learning fundamentals of echo because these patients are very complex. You have to first learn very well how to understand echocardiography and also learn how to assess these patients and then proceed further until you are able to manage these patients using echo. Because now we are in an era where you could easily become overconfident in using ultrasound in these complex patients and consequently make decisions based on your assessment, and these could be wrong decisions, and this can be harmful if we don't support our trainees to go slowly in that training pathway. And I also like to always remind my fellows, when you start learning echocardiography, you have to spend enough time mastering the views because there is no point of jumping into the excitement of calculations without obtaining the best views possible. Because many things will be based on adequate windows and adequate views. I know that our patients are difficult, but you should still learn how to optimize the views uh, as best as possible, because that will be determining the reliability of your calculations. And that's my other advice to those colleagues. And finally, echo journey is a never-ending journey. We're learning every day from our patients. We're still trying to do more research and get more data. And this is what makes it very exciting. It's very humbling and very exciting and very rewarding.
You're absolutely right about that, Hatem, and you and your group out there in London are teaching us worldwide. Every day, I feel like you guys are coming out with a new manuscript with more information. It's fantastic. So thank you again so much. It's eye-opening to see the work that you do. Truly honored and glad to have the ability to reach out transatlantic from chest to ESC. So hopefully we get to talk again in the near future whenever you guys put out some more guidelines.
Thank you so much, Nick. It was a great pleasure to meet you, and thanks for having me.
Pleasure's mine.
Thank you very much.